Thank you, Glyn. Slightly worrying when Glyn, after 10 years, says he's flummoxed. And I started 18 months ago, so bear with me on this one. It's a great pleasure to come in and talk to you about some of the organisational impacts of shared decision-making in Cardiff. And I enjoyed the session this morning, and I did start thinking about who our great one was, because I was very intrigued by that concept of the great one. But after disposing of David Beckham and Andy Murray, I was probably left with a fairly obscure Welsh rugby player who kicks goals with great precision, and I guess that's what we're trying to talk about today, that precision of measurement. So Lee Halfpenny is our great one, although I'm not aware he's actually made any quotes yet. I think the key word on this slide is beyond, because what I was particularly trying to do was to look at what happens after magic. In other words, when the money runs out, when the grant and the programme funding finishes, how do we make sure we've got a legacy? And secondly, pragmatic, because it will be fairly clear I'm not a scientist, I'm not a clinician, other than a pharmacist, which I think does count, but not in the context many of you talk about. And therefore, we're looking at the real pragmatic way of how we measure shared decision-making. And perhaps more importantly, to come back to the point that someone made, involving patients. Because there isn't always a decision aid, there isn't always an option grid, there isn't always a choice that has to be made in the way that you might for pure shared decision-making. But patients need to be involved in that choice of what happens to them, even if that option is no treatment. My role is as the Assistant Director of Patient Experience, and I guess that's where we've chosen to hang shared decision-making in the organisation. And I came into post when two things happened. One, the Health Board was formed, so it was a brand new organisation and fairly fertile in some senses for change. And secondly, magic was starting, and I was asked to be the bridge between the two. So we thought about where it fitted, where does it fit? And as I say, we've certainly hung it under the umbrella of patient experience, and I'll talk about that in a moment. But it's also about where does it fit in terms of the culture, because our organisation, as you'll see in a moment, is very large, very diverse, and it's unrealistic to expect a single culture to hold fair there. So we have to adapt, I think, shared decision-making to all those different cultures. And that's the patients as well, not just the clinical teams. The patients come from widely different backgrounds as well. How do we get airtime? We're no different to the US and other countries. We have financial issues, we have access issues, we have safety and quality issues. How do I get middle managers, like Glyn highlighted, to talk about shared decision-making if there isn't that imperative around measurement and performance management? How do we integrate it? I believe it's clearly unrealistic to take shared decision-making and drop it into the organisation as a separate entity. It's got to be blended in with clinical pathways, in the way we operate the systems, and that to me is the key challenge. And on the measurement issue then, what do we need to show about shared decision making? What do patients want to know about our approach to this? What do our clinical teams want to know? And what does the organisation want to know? And in our case, and this may or may not be true for yourselves, what do the regulators, the government, and other external bodies want to know as well? I won't read through this because you can get the key facts for yourself, but Cardiff and Vale is a large organisation. It covers all of the health services in Cardiff and the Vale of Glamorgan, which is in the south of Wales. And the key statistic, if you like, is on the right-hand side. We see about 1 million patients a year in our secondary care settings. Glyn talked about 120. The scaling up is phenomenal. If we want to really influence all those 1 million patient contacts, we have a job to do, and therefore we are in it for the long haul. We don't see this as a short-term initiative. From a patient experience perspective, because that's the umbrella we've chosen to hang shared decision-making in, we've got a very simple definition, and it's what it feels like to be a patient in the health board. And that covers all of the aspects. What's the environment like? What are our processes like? And it's all our clinical and non-clinical services. We believe that by influencing those, we can improve the patient experience. We've looked at the literature like most of you will have done. We've done our own surveys, our own work, and we've concluded the 3 areas we need to focus on are these 3 here. The first and last impressions, in particular about access. How do people get access to our services? The second around a safe, supportive environment. People want a clean environment, a safe environment, a low infection environment. And then at the bottom, the area that we're particularly focusing on today, they want involvement in care and decisions, and they want understanding. They want to understand the care they're receiving. We're fortunate in one sense in Wales. We've got a lot of policy drivers moving us in this direction to improve involvement and understanding of care. The Health Board is very clear. Its statement of intent says we want to involve patients meaningfully in their care. When they said it, they didn't know what they meant. You know, the reality was that they felt that was the right thing to do, but they didn't link it with shared decision-making or anything. They just felt as a board, half of which are lay members, that that was something they wanted the Health Board to sign up to. We've got healthcare standards in Wales, which all of the NHS organisations need to adhere to. And again, they've stated that patients need to be given time to discuss and opportunities to agree their care. Again, being, and I know this is being recorded, but being relatively cheeky, I don't think they knew what they meant either. Again, it was the right thing to say, but at the time they said it, they hadn't been fully aware of the work that was going around shared decision-making. NICE was referenced earlier, and we know there's now a standard around patient experience which highlights shared decision-making. And we've got a quality delivery plan in Wales and a Together for Health information delivery plan, all of which includes certain words that go a long way without actually mentioning shared decision-making to talking about involving patients in choice. So externally and internally at the top end of the organisation, huge drivers. But what about the patients? We've looked at the concerns, we call complaints concerns now in Wales, that people raise about the care they've received. And the common themes, I suspect, are worldwide. They weren't given information about choices. And bearing in mind these concerns come in down the line, not real time, this is after the event, they didn't get the choices, they didn't get the risks and benefits, and they got poor communication. So we have a mandate there from our concerns. We also have something called the Expert Patient Programme, which takes patients with chronic diseases through an educational programme to help them manage their conditions. And part of that is a free-form discussion to let them, for want of a better word, vent their feelings about healthcare. And you can read these for yourself, but they all imply that patients aren't getting the type of involvement that they want. So the reason for going through those is that if these are the drivers, if we're looking at measurement, we have to respond to what the drivers are asking us. The Health Board wants some measurement. You know, what is that? The external organisations like NICE and the healthcare standards people will want measurement. What does that look like? The clinical teams will want measurement. As Glyn highlighted, they like feedback. And also patients. Patients will need that feedback. The key to this, in my mind, is integrating that measurement with what we already do. And we've got a patient feedback framework in the Health Board, which is set in 4 quadrants. The top left we call real time. This is very short pieces of work asking very simple questions of patients about the care they're receiving at the time. The bottom right we call balancing, and that's around patient stories and patient groups. And the comment that someone made about involving patients, that's where we see patients will be involved going forward in blending our patient feedback work with our shared decision-making work. And the key to measurement for me is that we start to feed in the SURE method we talked about this morning, the DQMs that Glyn's talked about, and other measurement techniques into that framework. Then I can be fairly confident in the Health Board. It will get airtime, it will get integrated, and ultimately will start to a real change for the patient experience. And at this point I'm going to hand on to Maureen, who's our Assistant Director of Innovation and Improvement, who just wants to talk very specifically about one piece of work we're doing going forward in terms of measurement.
That's lovely. Thank you, Mike. Thank you, Glyn. I think as Glyn has quite rightly highlighted, we've moved from Magic 1 to Magic 2. Glyn we see as our architect, Mike as the builder, Myself, I'm the foreman, and I've got very helpful co-designers, one of whom is here today, that's Anne Jones. We also have Amy Lloyd and Andrew Ricks, and co-designers in the sense that it's co-designing with clinical teams, and clinical teams involve patients. So in moving from phase 1 to phase 2, which is actually about broad-scale implementation in an NHS setting, we have actually grappled, like everyone here today, with the measurement strategy. And considering really that this has been a Health Foundation sponsored initiative, it has been very interesting for us that actually even the Health Foundation couldn't define what they meant by measurement in terms of the implementation of shared decision making. So for us, we feel that the key elements of shared decision making in terms of a measurement strategy is about measurement for improvement. It is about meaningful measures, and this really is at the micro, the meso, and the macro level. It has actually to fit with existing measurement strategies, and within each of our own organisations, we will have different drivers for measurement. So it is very important that it fits and concords with your own measurement strategy. And equally, we had to build in the learning from Magic 1 to ensure really that it would have a strategic fit and fit seamlessly with the clinical teams, i.e. it shouldn't be burdensome, because if it was going to be burdensome, the clinical teams would certainly not buy into shared decision making. So with these factors in mind, we actually developed a driver diagram, which really is setting out the work that we have planned for the next 18 months. And really, on the left-hand side, you can see our goal, just about, and that is to involve more decisions in more patients in shared decision-making within our organisation. Now, we were very clear not to put in a percentage, because a percentage starts to put in a target, and then we all know what organisations are like. They all start to measure you against the target. But really, for us, the real success is about ensuring that more of our patients are actually experiencing shared decision making. And to enable that, we have got primary drivers, which are building on establishing a shared decision making consultancy framework. It is about engaging more patients within shared decision making. It is about embedding and spreading and ensuring that we learn from phase 1. And it also is about education and training, because obviously it's very important for us that our new clinicians are actually adopting a shared decision-making approach in terms of how they interact with patients in their clinical consultations. And I think what you can see from the driver diagram is when you start looking at the measurement section, it really stands out that what we're actually measuring really are process measures. So it's talking about the numbers of patients, etc., but very little in terms of the quality outcomes for patients. We touch a little bit in terms of patients having better knowledge and feeling more empowered. But actually, what we don't really define is this perennial question, is anyone better off? So what we've tried to do within this in terms of our organisation and building in on process measures and performance measures that we currently have in vogue within Cardiff and Vale is actually to align the model for improvement with the results-based accountability framework. And the results-based accountability framework is very much a common sense approach to shared decision making and making decisions across organisations. And it very much looks at how much did we do, how well did we do it, and is anyone better off as a consequence? And that fits in seamlessly with the model for improvement. I think really it is actually the quadrant, is anyone better off, that is the most challenging in terms of shared decision making. And I think from what we've learned from this morning, that's something that I think everyone is still actually grappling with. So how much did we do and how well did we do it? I've given some examples there, and they're basically numbers of patients, numbers of referrals, etc. How well did we do it? The percentage of patients involved, the percentage of patients where shared decision making was used, the percentage of consultant referrals avoided, etc. And then when we started getting to, is anyone better off, there were some very interesting measures here. I think percentage of patients whose reported pain has decreased, with actually a decrease in their pain score, percentage of patients that report that they feel more empowered. So these are all very useful, but actually the most surprising one, and this came from the patients themselves, was actually whether or not they had a better night's sleep, if their pain management was such that they had a better night's sleep. And using the RBA approach and actually involving patients as part of that measurement strategy, that's where you actually get those nuggets of gold. And that's really what we all need to be aiming for, is actually deriving from the patient's perspective whether or not they are better off. Because as Mike has highlighted, policy identifies that shared decision making is good, but really, does it really matter as long as at the end of the day, whatever we're doing, the patients feel that we're actually improving their quality of care? And I think that really is for us the important thing about shared decision making in terms of implementation in the NHS setting. So in conclusion, this is Sisyphus, and this is we see as Glyn, as our architect, pushing the boulder up the hill. I think, there isn't an easy answer. I think that's really coming through from the conversations that we've heard today. But surely one of our key metrics has got to be, is anyone better off? And I think, while Glyn is Sisyphus and the architect, he is being ably helped. We've got Mike as Superman, I as the foreman, Batwoman, and we've got a number of superheroes which are our co-designers, and that's Anne, Amy and Andrew, but most importantly, clinical teams and patients. So thank you for your time.